181th session on 19th of October. I would like to invite Dr. Monica Vasudev from US to introduce the session. Thank you.
Thank you, Saurav, and welcome to this weekly session. I'd like to introduce, and we are very honored to have Dr. Nisha Nigil Harun, a distinguished endocrinologist and the director of the Endocrinology Clinic in Etobicoke, Toronto. With a wealth of experience, she served as an associate professor of endocrinology at the Northern Ontario School of Medicine in Canada. Her expertise in the field of precision medicine, particularly as it relates to endocrinology, has been instrumental in advancing personalized healthcare approaches, improving patient outcomes by tailoring treatments to individual needs. Today, she brings her extensive knowledge and passion for precision medicine to share insights on this cutting-edge approach in modern healthcare. It is my pleasure to welcome her today. Thank you.
Thank you. Thanks, everyone. Thank you, Dr. Monica. So we'll get started. Am I audible? Okay, yeah. So share my screen there. All right. Yeah, so you see my screen, right? Okay, thank you. So basically, so my background in endocrinology and dealing with chronic diseases day in and day out enabled me to develop a key interest in this subject. In the field of endocrinology, we are already doing and practicing some aspects of this. So we have been fortunate to experience real-time the technological advancements. And also we do have a lot of AI-enabled tools that are put to good use already in the field of endocrinology. So no disclosures related to this presentation. So precision medicine, basically, it is an innovative, like novel approach that is gaining momentum in healthcare thanks to AI and other advancements in technology and genomics. Basically, this is an idea to tailor medical treatment and prevention strategies to individual, not on a population basis or a cohort basis. And this will be done using someone's unique gene makeup, environmental and lifestyle factors. So that is what it comes to. In the past, originally medicine was practiced as intuition medicine or eminence-based medicine. You know, you were following an expert and their guidance on a particular topic. And we mainly went by signs and symptoms of disease presentation. And right now we are in the era of evidence-based medicine. Basically, this concept actually evolved out of Canada, and whatever evidence we consider as strong or category A is based on clinical trials. But I mean, as we all know, it is quite time consuming and takes up a lot of resources to generate this kind of level A evidence. And our future is going to be precision medicine, and it's mostly driven by algorithms. So this whole concept was first evolved or reported, officially published in the report from National Academy of Sciences in 2011. So basically, the goal is to understand how we can tailor medical treatment to individual characteristics. So it's kind of personalized medicine in a different way. Overall, we hope to improve their outcomes, taking into consideration genes, environment, and lifestyle. So in the overall landscape of clinical medicine as we practice now, these are the 4 pillars. So classically what we do is reactive medicine. So that's hospital-based, or we treat the patient once an outcome has occurred, whether it's hypertension or diabetes or cancer. And then we do preventive medicine, trying to prevent, for example, cancer screening helps to prevent the onset of cancer, or metabolic disease prevention, and then participatory medicine, and then the personalized medicine. So that is where the precision medicine comes in a big way. And like I said before, a lot of the advancements in this field is going fast or in an accelerated manner because of the advancements in genomics, which is focusing mainly on pharmacogenomics, and also there are applications based on big data extracted from sources such as electronic medical records and gene sequencing. And we are looking at actionable gene identification. Of course, we do identify a particular gene, but then what are you going to do with that? And then there has been advancements in the field of therapeutics. So in terms of CRISPR and other antibodies and other technologies. And then diagnostics are also advanced. So we have advanced biomarkers now available, and radiomics and radiogenomics also now available. And also various new devices that are available through which we can detect circulating tumor DNA from peripheral blood or peripheral tissue, or even performing molecular genetic studies on cytology and biopsy specimens, and then advanced levels of drug screening. So precision medicine is about, when it comes to therapeutics, it's also about providing the right therapy for the right patient at the right time. So it's not novel. We were always doing it, but we are taking a more personalized approach by understanding the biological variation. So now we can understand the metabolic state, and then leveraging whatever data we have collected to identify subcategories. For example, in the field of diabetes, we can subcategorize diabetes. Maybe type 2 diabetes is a heterogeneous disease. It's not one disease anymore. And then depending on individual characteristics, we can categorize and treat accordingly. So these are some of the modern tools, like I mentioned, gene sequences, omics testing, microbiome analysis, especially for GI and gut microgram. There is a lot of interest now. 3D medical imaging, GPS, and the wearable physiological sensors. In endocrinology, we are using continuous glucose monitors to understand the real-time glucose variability and patterns. So it has been a wonderful tool to understand and treat or titrate insulin regimen, diet, and also the behavioral aspects. So these are considered invaluable tools. So wearables play a big role. Now we are already using them in clinical medicine. And then the video cameras and implantable sensors. And of course, EMR is a big tool. So we are in the process of integrating big data from various large electronic medical record systems worldwide. And social media is also one powerful tool if used appropriately. So basically, we are looking at actionable mutations, druggable targets, and of course, then comes the validation part, so that we can ensure that the target actually has a causal, because there's a lot of noise. So we have to make sure that the target actually has a causal role. So coming to precision medicine, these are the several elements of precision medicine: genetic profiling, environmental factors, lifestyle factors, and big data. So genetic profiling means we can analyze an individual patient's genetic makeup and identify specific mutations or some variations that may influence their disease risk or treatment response. Now, coming to environment, we can try to understand how a person's environment affects their health, and lifestyle, evaluating how individuals' lifestyle choices impact their health and treatment outcomes, and big data, using large data sets and advanced computational tools to identify patterns and do predictive analysis. So that's where this whole algorithm comes into play. Now, coming to the applications of precision medicine, we are looking at targeted therapies. So we are able to develop treatments that target specific genetic mutations or molecular pathways in certain diseases, for example, cancer. And then coming to pharmacogenomics, selecting medications and even medication dosages precisely based on genetic profile so that the efficiency is maximized and the risk of side effect is minimized. Then we can use these algorithms and tools to predict disease risk. So it's primordial prevention, identifying a particular cardiovascular gene so that we can say that, okay, this person has this particular gene, and so maybe they're at risk of getting heart attack, and they need to be started on statin and other preventive measures sooner than others. So identifying higher risk for certain diseases based on genetic factors, and finally, early disease detection based on molecular markers. So this is one example where we are looking at the whole emphasis shifting from reaction to prevention. For example, in the field of breast cancer, so we do understand that certain BRCA mutations changes the risk of breast cancer. So some women have these mutations and they have up to 85% lifetime risk of developing breast cancer and up to 60% of developing ovarian cancer. So once we know that what type of mutation is identified, then we can aggressively screen family members and associated clinical prevention modalities can be applied. And even this has an implication on treatment also. So we can precisely identify who is at risk for progression. So maybe such women need more frequent mammogram and early mammograms and prophylactic surgery and chemoprevention. So currently there are around 15,000 tests available. A lot of tests are available, and we are testing around 3,000 genes. And anything from hearing loss to sudden cardiac arrest in endocrinology, we know it's being used in diabetes, cancer, various types of cancer. And some of these tests have predictive capability and ability to potentially spot the disease before we actually start to get symptoms. And coming to pharmacogenomics, one example from cancer oncology for this particular cancer, breast cancer, if we identify the Herceptin tumor marker, then some patients will benefit from receiving Herceptin and other drug targets, for example, lapatinib. So there are these commercial platforms that offer these testing. Oncotype and MammaPrint, these are some of the advanced genomic tests. So they will help identify the right course or best course of treatment for the patient. And we can also predict in the case of adverse reactions, for example, warfarin. It used to be like the traditional way of adjusting the dose of warfarin is by doing INR, and it's mostly trial and error and individual judgment. But then the patients were still at risk of inefficiency or overdosage and causing a lot of times we used to see patients getting hospitalized with bleeding or failure of warfarin treatment. But now the recent regulation recommends having genetic testing done in patients on warfarin before, so that we can precisely adjust the dose. And I think knowing what works and what doesn't work also gives more confidence to patients to take particular medication. So that way the compliance, one of the big challenge we see is behavior and misinformation. A lot of people do think that, these medications don't work. They have lost faith in big pharma. So even there is a lot of misinformation. For example, statin, so many patients are now stopping statin. So if we identify the right candidate who's likely to benefit the patient and show them the mutation or whatever the response, then they are likely to take it rather than believe the misinformation. So we can tailor and ensure that the patients get fewer side effects and are compliant with the medication. So we can also often, I get asked about the risk of muscle pain. So patients are afraid to even start statin, or they are also afraid of getting glucose intolerance when starting statin. So once we know precisely what their risk is, what their genetic makeup is, I can reassure them, right, showing evidence. Again, tumor markers, subclassification in the field of cancer, identifying a specific biological marker and then targeted treatment. That will lead to positive effect in every patient that we are treating. So the identification of novel biomarkers play a big role here. So again, coming back to how traditional medicine used to treat cancer, we were using surgery, chemotherapy, and radiation. So this is how it conventionally looked like. And now we are looking at advanced personal treatment, and we do genetic sequencing, locate cancer-causing genes, whether it's upregulated or downregulated, and immunotherapy is the mainstream for cancer treatment now, and targeted therapies, turning a specific gene on, off. So it's very precise. Another potential application is that, interestingly, on a large population base, a particular medicine may show weaker efficacy, but when we identify a subgroup of patients who are likely to benefit, they might see better response rather than general population. We always see that in clinical practice. For example, I use semaglutide or Ozempic in my practice a lot for managing diabetes, or sometimes for weight loss, cardiovascular prevention, so on and so forth. So there are some people who respond excessively. Like sometimes we see exaggerated GLP response to GLP and exaggerated glucose lowering or exaggerated weight loss. And there are some people who may not respond to semaglutide or Ozempic. They may not lose weight. So this is possibly partly mediated by the genetic makeup also. So if I can be reassured, or I can tell the patient that, okay, you are going to benefit immensely, so take this medication over SGLT2 inhibitor or canagliflozin, it is reassuring and kind of strengthens the physician-patient relationship also. Another example from the field of oncology, recently there was a lung cancer drug, gefitinibab, which was demonstrated to have not met survival advantage when it was studied in a general population. And it was actually withdrawn from the market, but then they came back and demonstrated that patients with epidermal growth factor mutations actually had benefits. So now it has approval as first-line treatment in this subset of population. So some medications are coming back. So coming back or summarizing the benefits of precision medicine, so we are able to more accurately do disease prevention, and treatment strategies can be implemented accordingly. Patients may not develop side effects from medications, or less side effects, because we are carefully choosing the medication for them, and improved efficacy as we just saw, and of course cost efficacy in healthcare delivery, because we are not doing reactive medicine, we are doing preventive medicine. And that is obviously a big shift from reactive to preventive healthcare, as I just mentioned. Now, I have some data to show that what is happening in the field of diabetes, because it's the most common chronic disease and it is tied to a lot of adverse outcomes, and it is going to affect probably 1 in 2 people thanks to the obesity burden and lifestyle changes. So diabetes is a relevant field to all of us. So whether it's primary care or any specialty, every day we see patients with diabetes, right? So there has been a lot of advancements in the field of diabetes and a lot of money being pumped into precision medicine. So these are some of the larger precision medicine initiatives happening across the world. In the UK, there is UK Biobank. They are studying 500,000 people. And similarly, in the US, there are several programs going on, investing millions of dollars, and millions of people being studied across the world. Even Saudi Arabia, European Union, there are novel diabetes projects are happening. So if you look at diabetes, previously we used to think that it's a homogeneous disease, but it's not the case anymore. Obviously, we know there is type 1 diabetes and type 2, but then even within the type 2 diabetes, now there is 1.5 diabetes as an intermediate type. Some patients have insulin deficiency and some patients have insulin resistance. And then we have the monogenic forms of diabetes, then monogenic diabetes in pregnancy. Then there is insulin deficient type 2 diabetes. Then there is predominantly insulin resistant type 2 diabetes, pre-type 2 diabetes. And obviously we often see that some people are obese, but they never develop diabetes. So there are different types. And then even type 1 diabetes, thanks to genomics, or we can identify the stage 1 and stage 2, especially in relatives of patients with type 1 diabetes. For example, in the application of genetic profiling in diabetes, mainly we saw some mutations being identified in this category called MODY, or maturity onset diabetes of the young. There are mutations identified which are of therapeutic potential also, mutations in HNF1A, 4-alpha, and GCK. And then in type 1 diabetes, there are HLA markers that can predict susceptibility and aid early diagnosis, because there are some molecules that can be given to individuals with early early phases of type 1 diabetes, based on the genetic makeup, and they have to have certain type of gene, and then they have to have positive antibodies for type 1. If we identify this before they even get the disease, for example, somebody's, example, you're treating a patient with type 1 diabetes, we can screen their siblings and find out if they have 2 antibodies and this gene, then we could use an antibody-based treatment to prevent the onset of diabetes in that family member. Even at least we can delay the onset of type 1 diabetes maybe by 5 years, especially when these children are small. Like, we don't want them to get type 1 diabetes at the age of 5. We could potentially delay or prevent the onset of diabetes using these medications. They're very expensive, but it's possible to do that now. So this is one online app that is available to identify the probability of MODY in certain patients. So again, identification is important, and it has a practical implication because we can decide precision treatment if correctly diagnosed. And then again, rather than treating or having a misdiagnosis, sometimes MODY patients may respond to sulfonylurea, so we don't have to give them insulin. So that typing is very important. We've seen some patients go back from insulin to sulfonylurea, interestingly. So unnecessary pharmacological treatment and reduce the need for frequent blood glucose monitoring. If they are not on insulin, if this is very mild, responding to a small dose of sulfonylurea, they don't have to be checking blood sugars several times a day. It causes a lot of anxiety and concerns around frequent testing and adjustment of insulin dose, etc. There is also risk of hypoglycemia. Now, phenotypic characterization of type 2 diabetes is still complex. We are still waiting for more precision in this regard. So we need more data on the subcategorization. Right now, mostly the subcategorization is based on clinical features and age of onset, BMI, and presence of autoantibodies. So antibodies we check include GAD and islet antibodies. And there are a couple of other antibodies too. So basically, we are still relying heavily on using clinical features to differentiate type 1 and type 2 diabetes with good sensitivity, but it's not perfect. So we look at BMI, age, weight loss, his presentation of osmotic symptoms at the time of diagnosis, and incidence of ketoacidosis, glucose level at the time of presentation, A1C, HbA1c, etc., and presence of other autoimmune conditions. But again, we are certainly limited by the big interplay of genes. There is a complex interaction with various genes. So, but then we do know that some people develop diabetic retinopathy or nephropathy faster, or they get it in an aggressive manner compared to others. So there is a big genetic predisposition. So that can be identified by understanding their genetic makeup. Similarly, the cardiovascular complications also might frequently occur in patients with certain genetic polymorphisms. And of course, there are other risk factors too, like sedentary lifestyle, high-fat diet, BMI, and even environmental pollutions, air pollution. So it's a multifactorial disease. Now, this is the effect of genetic variants influencing treatment response. So I briefly mentioned how the treatment response may vary in patients receiving Ozempic or semaglutide. Similarly, we have seen that South Indians respond more to metformin, and also some Asian populations, especially when they have these genetic variations. And some people with this genetic polymorphism may not have much effect when they are treated with metformin. Similarly, we have seen certain polymorphisms causing increased sensitivity to sulfonylurea in the Danish population and less response to sulfonylurea in the Scottish population, and similar response heterogeneity has seen based on various racial profiling also. This is one of the genes identified to cause dietary interaction with type 2 diabetes progression. So in one of the studies, they looked at TCF7L2 gene and polymorphism. So with the specific suballele, they found that those patients are prone to develop diabetes. But interestingly, Mediterranean diet kind of modified the genetic risk, it prevented the progression. Now, coming to precision diagnostics, we use certain markers and diagnostic testing, and then we can come up with probability scores using other parameters also. These are cumulative scoring systems. So this is when biomarkers can be of use. So there could be variants of HbA1c. Right now we use just HbA1c, but it could be falsely normal or falsely elevated. So that way we can, if it'll be beneficial if we can identify HbA1c variants, because it's a very good prognostic and diagnostic marker for diabetes. And C-peptide is something we use in type 1 and type 2 to differentiate. And also in type 2, if somebody has very low C-peptide, we can assume that their body had stopped making insulin. So it gives us some directions as to whether we should be adding Ozempic or insulin in this patient. Lifestyle and environmental factors. So personalized nutrition plans and physical activity regimens can be planned depending on the genomic profiling. And of course, we have to consider socioeconomic status also. So I'll spend a little bit of time on nutrigenomics because this is getting popular now. So there are some applications in obesity medicine and also chronic disease. I do use it in some of my diabetes patients, and I do weight loss medicine. I do practice obesity medicine. So it's been a good tool. Not perfect, but we do get some additional information about nutrigenomics based on the gene profile. But then the concerns, like it's still not ready for prime time. We still don't have robust and reproducible results, and the cost is very high, and the methodological issues are still there. So there are big limitations, and we are still facing ethical and regulatory challenges. And again, a lot of advancement has been made, and we do get a lot of data out of these tests, but then we are not equipped with the right knowledge and right tools to make or understand what this actually means. Sometimes we struggle with explaining the results to the patients in terms of clinical counseling. So this is a bit overwhelming in that regard. We don't have trained professionals enough to do this job. So commercial kits are available. I've seen there are some kits available in India also. The kit that I use is through a vendor. It's a startup from University of Toronto. Called Nutrigenomics. So I have partnered with them. So I do offer it as a service to my patient. So this particular kit or the assay, like they can check for 70 genetic markers. So basically they'll send you the envelope to your house, and then you spit on the kit, and then they'll give you the results. Then we go through the personalized. Sometimes they give you recommendations also. Most of the commercial kits are now able to look at metabolism and behavioral aspects. Like this is very important. Mental focus, whether they are able to do physical activity in a sustainable fashion. What makes somebody more prone to follow a certain diet. So it's kind of a behavioral aspect is looked at nicely, and then they can comment on eating habits, even pain tolerance. Pain is something people complain a lot when we advise them to exercise. So it's important to know that their pain tolerance, their aerobic capacity, certain food intolerance interact with the dietary preferences and choices, and body composition, nutrient, micro and macronutrient requirements, exercise performance, and even the risk of injury. Some people are prone to get Achilles tendon injury. So those type of granularity can be obtained from these studies. So athletic performance and physical activity is very important. Sorry. Yeah. So this is how the result will look like. They will comment on the nutrient, micronutrient composition, vitamins, minerals. So, and then there is a little bit of recommendation at the last column, on the last column. So this is one of my patients. So again, we do sit and have a discussion about the findings. Again, if there are certain types of obese patients who do not respond to medications or interventions, sometimes we may not see good response. We often say that, oh yeah, your metabolism is slow. But why is it so? If we do genetic studies, sometimes we are able to identify that the results are slow because of these genes. So for example, in the case of FTO gene, they actually did very well after high protein or low protein. So depending on the response of the polymorphism, so there is still, we cannot simply recommend everyone to take a high protein diet. So the response may vary depending on the genotype and polymorphism. And similarly, another test where a DNA-based diet in the real world, when they gave precision medicine, the weight loss was sustainable, more weight loss was seen, and more success with glucose lowering. So that is why some of these nutrigenomics or other genomic testing precision medicine tools are useful. Coming to the specific brand I use, so I'm familiar, that's why I'm saying, but there are other vendors also, so I don't have any partnership or commercial relationship with them. So this is a startup from University of Toronto. It is actually now a multinational company, widely used, and actually founded by nutrition experts from University of Toronto. They are also now trying to provide pharmacogenomics also. There are kits available for fertility and weight management. I'm showing this because you can start using this in your practice, right? So some takeaway information for real world practice. So pharmacogenomics is well known. So this is something I have started to offer to my patients, because sometimes patients come and say, I've developed side effects. I've developed, for example, in the case of statin, I have muscle pain. And in case of Ozempic or semaglutide, I'm not losing weight. I'm using the full dose. My appetite is not suppressed. In fact, my appetite is more after taking Ozempic. So we'll often wonder, how is that even possible? So there are some people who have abnormal or unpredictable reactions. So pharmacogenomics may be improvement. Maybe that patient should have put on insulin, or maybe sulfonylurea or SGLT2 inhibitor, not Ozempic. So things like that, right? Even between sulfonylurea and thiazolidinediones, there is some heterogeneity depending on what type of. There is one study showing the HbA1c response based on the genetic makeup. So again, there was a gender-based difference in glucose lowering effect with thiazolidinediones and sulfonylurea. So there are individual differences. And if you can genetically identify markers of high insulin resistance, then we can actually tell the patient, listen, you may have to go on semaglutide, not a DPP-4 inhibitor. Januvia alone, a milder drug, sitagliptin, may not improve your diabetes. You may have to go on something stronger like semaglutide. Rather than wasting time, sometimes they say, well, let's try something mild. Let's use Januvia for 6 months, then try semaglutide. No. So if the patient has genetic markers of high insulin resistance, then you may straight away, right from the get-go, put them on semaglutide, help them lose weight and reverse their diabetes instead of wasting time and letting the disease progress. Similarly with GLP-1, semaglutide or Ozempic, I'm using the name Ozempic again because it's because it's popular and and everybody's familiar. So for example, if the patient has lower insulin secretion, we know that from the genetic makeup, Ozempic may not be the right choice. Even if the patient is obese, if the insulin production is less, they may have to go on insulin lifelong, at least basal insulin. So we can reassure. And of course, Ozempic may help with weight loss, but they may have to use both. So like I said, the clinical markers of low beta cell function or insulin production are associated with less response to GLP treatment. So we saw that genetic variations can influence efficacy and side effects of medications. We saw how the response might differ between even the newer drugs like GLP agonists and SGLT2 inhibitors. So in the case of SGLT2 inhibitors, there is a certain polymorphism can occur and predict the glycemic control. So this is what I'm starting to offer the same company is offering pharmacogenomics. They look at the cost. So each test is around $400. So cost is a concern always, and it is out of pocket. The insurance companies have not started cover these tests in most cases. So again, the technology plays a big role, not just genetics. Technology plays a big role in precision medicine and personalized medicine. So in the field of diabetes, we use continuous glucose monitors such as Libre or Dexcom. So we get real-time data to adjust the insulin dose, food intake, exercise, even risk of hypoglycemia, medication dosage, and compliance, and even less anxiety and better HbA1c and long-term clinical outcomes based on continuous glucose monitoring. And I do a lot of telemedicine. I have patients the statewide, because I do telemedicine all the way up to Northern Ontario, the remote populations, First Nations communities. I'm able to see these patients through remote monitoring and virtual consultation. So that's been another technological advancements. So I'm heavily involved in telemedicine and distant. And because of these remote monitoring tools, sitting from my home, I can see the real glucose data real time for a patient who lives 400 kilometers away. So this has been a big advancement. Even during COVID, this was a very useful tool. So again, precision prognostic. So whether a particular a gene or variant is predisposing these patients to develop diabetic retinopathy or cardiovascular disease or nephropathy, if we can identify soon enough, we can aggressively treat the risk factors, use ACE inhibitors or ARB and statins early, and use higher dose and titration. So AI again has changed is changing, and it's also happening in the field of precision medicine, healthcare in general. So AI is going to accelerate the application and accelerate the research. So AI-powered early detection is already happening. Even in our EMRs now, we are using AI-enabled tools, so we can also come up with our own customized tools to identify patient patterns, patient response, and patient behavioral aspects. So our role as a physician is also changing. Again, coming to clinical barriers, we still don't have clear consensus on how to treat these patients and findings. Cost is a big concern. I mentioned some of these DNA kits cost $400. And again, reimbursement, insurance companies have not caught up on these aspects, and the specificity and validation is still a problem. We still don't have lack of good predictive markers, especially for genes for serious adverse events, anaphylaxis, and other responses. And then functional studies, and we need to broaden these studies across ethnic groups and other racial groups. And sometimes there's a lot of noise in the data. We have to understand what outcome is relevant to your patient. So that needs to be more precise. And of course, there is a lot of data being bombarded onto us. So we need some decision support tools and algorithms that can be integrated into our EMRs so that we can efficiently practice this and use these tools. More tools are being created, but then how do we integrate time? How do we use these tools efficiently? So it's a matter of technology and innovation. And we have to demonstrate that these approaches are cost effective. Technical barriers, big data, they're still in silos, that we are always concerned about privacy and security, usability, etc. The big data, again, is also spread across spreadsheets, apps. There are numerous apps studying different aspects of disease, behavioral aspects, etc. And then even cloud and even social media, etc. So privacy and data security, even within our own clinic, is a concern. So this is in summary, again, we cannot ignore the social aspects, so improving drug access and all that, lowering the cost of medication, and understanding more about the heterogeneity. So all those puzzle pieces need to be solved before we can go on to practice precisely and in harmony. Yep, I think that's it.
Thank you so much, Dr. Nisha, for insightful session. I would like to invite question answers. Dr. Chong is here. He's the chairman for CMAAO. Dr. Chong, you want to say something? We cannot hear you in case you're talking. I believe you joined remotely. Dr. Chong, we cannot hear you in case you're talking. You may want to rejoin. Dr. Angelique, you want to say something?
Thank you. Thank you, Dr. Nisha, for a very, very enlightening topic and speech that you gave us. I just have one or two questions here. I would like to know, you talk about nutrigenomics. How is there any contact numbers, and can we contact you if you want to get involved and help our patients with that. And so that's the one thing. I saw you talk a lot about diabetes. So I presume that diabetes would be one of the diabetes patients would benefit quite a lot of some of these precision medicine. And you mentioned something around warfarin. I'm not sure about the warfarin. You said that the FDA recommends testing for warfarin. What would one use in a country like South Africa, where I am coming from? Just around the warfarin, and then and I saw you posted your email. I'm going to write it down now. Thank you.
Of course, yeah. I can definitely share information about the nutrigenomics. I can connect you with the company. So they're based in Toronto, and they have, yeah. So it's a good tool, but again, you have to have an open and frank discussion with the patient. Listen, this may not solve all the problems. Like this may not be the magic remedy, but you will get to know some more. Some people like that kind of information. That granularity. So you have to understand the patient's need and then offer it. Otherwise, they may be disappointed, So that is one aspect, but mostly people have found it beneficial. Now, coming to the warfarin, yeah, I think it's about the pharmacogenomic testing so that we can guide what dose to be started, whether it's 2 milligram or 4 milligrams. So that really helps. Based on these certain genotypes as CYPT, CU9, and I don't have much details, but again, so there is a recommendation for precise dosage and all that.
We can see you, Dr. Chan, now. Go ahead.
Thank you, Dr. Nisha, for that wonderful presentation. And it was fascinating to understand all these precision medicine. I once attended a very interesting statistics session where they talk a lot about N of one statistics, where the N, instead of thousands and thousands of patients, they use one patient, and how each person is a parabola, and this leads on to the use of precision medicine, in particular dosing of drugs and so on. What are your thoughts on this?
Check and muted.
Yeah, my concern is that, of course, this is what the future, and I think we're already living in the future when it comes to certain diseases, especially oncology. But again, how quickly can we extend this to other fields is something we don't know. For example, hypertension. Can we cherry pick one hypertensive medication? That is because right now we start with diuretic, then we add calcium channel blocker, beta blocker. So can we go back and say, okay, this patient should be started on a beta blocker first or a calcium channel blocker first? So I think we are not there yet in most diseases. Probably it'll happen soon, right? And we don't have probably the validation of these tests, and there's still a concern, right?
Thank you. Thank you very much. I also noticed that you use a lot of CGMS, continuous glucose monitor. And do you find that extremely useful in the management of obesity and diabetics?
Yeah, so in the field of obesity, the main challenge is insurance. A lot of patients like that aspect, when they can watch their calorie and watch real time how much the glucose spikes. So in my personal opinion, it's a very good behavioral tool. But the problem is that the insurance is not catching up with this, right? But even with diabetes patients on tablets, the CGM, the continuous glucose monitoring device, is not covered by insurance companies here. So that's a big challenge here, which we are all trying to advocate, because even if they're on metformin, in order to prevent further progression, ideally they should be using a continuous glucose monitor. But the argument is that in a normal euglycemic individual, sometimes we do get a lot of false alarms but then I do think that the glycemic variability is a long-term predictor of cardiovascular mortality and all that. So even if the HbA1c is normal, when you wear the CGM, you really see the spikes, and the glucose spikes for 1 hour and then it drops. The average, the HbA1c might be normal. We may miss, especially in South Asians with a lot of insulin resistance, we may miss, or there will be a delay in diagnosis if you are only depending on HbA1c. Once they start wearing CGM, we'll diagnose these things early.
Yes. So the key is glycemic variability.
Exactly. Yeah. Yeah. It is linked to cardiovascular issues too, right? Autonomic neuropathy. And yeah, so we're starting to know more about that aspect.
Fascinating, fascinating. Do you all use what CGMS do you all use back home? Which
In
brand do you use?
Canada, now we have the Dexcom G7.
Yes.
Yeah, so it can be worn for 2 weeks on the arm and the abdomen. They're smaller. And then the Libre 2, but we don't have Libre 3 yet. Abbott Libre, it's going to be again smaller and less warm-up time. They're waterproof. Patients can go swimming and, even for 30 minutes. And it's all integrated to the Apple Watch and even Amazon Alexa. So you just have to ask Alexa to tell your blood sugar. And the apps are also becoming more user-friendly. And the device itself is very small. It's getting smaller now. And it doesn't hurt. Recently, today, I saw a publication about non-invasive glucose sensors also. It's based on magnetic radiation. So that's going to be the reality in not even continuous. They're more accurate than, maybe I can post that link in the group.
Yes, please.
Very interesting.
Magnetic. Wow.
It's like, yeah. So non-invasive glucose meters.
Oh, that's impressive.
Yeah, there are 4 or 5 startups. There's one in Israel, one in India, Germany. I think I posted it. Yeah.
Dr. Monica?
Yeah.
That was a fantastic presentation. Thank you so much, Dr. Haroon. It was very enlightening. I'm not in the field of endocrinology. What really sung to me is getting genetic evaluation to understand risk factors for Coumadin use. I mean, it's so widespread that, it's such a simple concept, but to be able to understand who are super responders, who are going to be suffering adverse events. I think access to this type of medical care is going to be uneven. I think that people who are involved in making these decisions about who to apply these tests for is going to be uneven. I think cost is going to be a big issue. You had talked about that as well. But where do you see precision medicine in 5 to 10 years? What field is going to be the leader besides oncology? Let's put oncology aside. Where do you think that precision medicine is going to really take off?
I guess I have this Canada bias. So here, when the continuous glucose monitors were first available, we could only, or the GLP-1, right? We could only use them in select patients, but within 1 or 2 years, the government, the general insurance, they started to offer it to everybody, right? So we've been fortunate in that regard. But coming to the applications, I'm not sure, but I think I do see, we are not talking about 10 years anymore, right? It's going to be 2 years or 5 years. It's already happening. And with the AI element, it's going to be less than 5 years for sure. We are already talking about an artificial pancreas as a pump, right? The insulin pumps are also, I forgot to mention that insulin pumps are also AI enabled now. So the algorithms and all that. So we are already starting to see, we are using them already. But I guess the applications may be potentially more for the behavioral aspects, like obesity medicine maybe will catch up sooner. But the other, I'm not sure. Inflammatory diseases, I'm not sure. There's a lot more to it, right, than gene and environment. The autoimmune diseases, maybe, I don't know. I haven't read much about the other fields. Oncology and obviously chronic disease.
I feel that with the use of electronic health records, that there's so much data that we're inputting into their records that AI might be able to do some of those earlier diagnostic approaches, the clinical approaches, and that intuition will be more AI based. And that might lead in to say that maybe you should do the genetic testing And then we can flip from the intuitive medicine to the future of medicine to use all of these tools
Yeah.
that you.
Yeah, I mean, my husband is a rheumatologist, so I know he's the chief of rheumatology at University of Toronto. Their department, they do a lot of genetic studies and all that, but I'm not sure how much. Maybe I should ask them. Like, you know, this whole, they are very big on genetics, and yeah, but I don't know how far they are in terms of precision medicine. But in our case, like, we are already using it, right? In especially for the behavioral aspect with CGM, and that component is fulfilled already in endocrinology.
Fantastic. Thank you again.
Do you have any other questions on the floor?
Well,
I
if
think-
there are no more questions, then we like to thank Dr. Nisha for her wonderful presentation, and really at the cutting edge of a lot of advances in the interface between AI, medicine, technology. I mean, it's just refreshing to hear such a well put together presentation. Thank you, Dr. Nisha, and we hope to hear from you again in the near future for further updates on what's going on in this area.
Thank you.
So I think, thank you, Nisha. I believe it's 1 a.m. So I think it's pretty late for you. You look fresh, but I believe we will not take more time. I think with this note, we'll end the session. Thank you so much.
Thank you.
Thank you, everyone.
Thank
Bye-bye.
you.